And today we have Dr. Ciaran Scallan, who is an assistant professor at McMaster University and a staff respirologist and St. Joe's Healthcare Hamilton and Hamilton Health Sciences. He runs subspecialty clinics for patients with interstitial lung disease in addition to the new satellite lung transplant program at St. Joe's in partnership with the Toronto General Hospital. His research interest includes patient-reported outcomes, health-related quality of life, basic mechanics, and interventions for pulmonary hypertension and interstitial lung disease, and early-phase clinical trials. And Dr. Scallan is also a recipient of a $20,000 research grant a couple of years ago that was on a study on cough. So, Dr. Scallan, if you might want to say a few words on that before I introduce Mark.
Sure. Thanks, Ciaran. Just, I guess, as an update to that bio, I'm now full-time at the University of Toronto in the Toronto Lung Transplant Program. I was last year working with our satellite clinic in Hamilton, which unfortunately we don't have running at the moment, but hopeful maybe to get that going again. But to your second comment, yeah, we're very grateful to the CPFF for funding to help us start what is now an ongoing randomized controlled trial for patients with pulmonary fibrosis and severe cough. So I think we've enrolled about 15 or 20 patients so far and are really moving well through things. So again, many thanks to the CPFF for funding this very, very understudied and very important work.
Well, thank you. And it's an honor and privilege today to welcome Mark Ashcroft, our board member on the Canadian Pulmonary Fibrosis Foundation board. And he's also an IPF patient. He received a double lung transplant. It's going to come up to 3 years in January, is it not, Mark? Yep. And he's a retired firefighter and also a paramedic. So, Mark, if you'd like to say a few words.
Yeah, I'm glad to be here today and hopefully answer a few questions and give people some information.
Great. Thank you. And now we'll turn the floor over to Dr. Scallan for him to start his presentation.
That's great, thanks, and I'm so grateful Mark could be here too. I tell patients in the clinic all the time that I can talk till I'm blue in the face, but you'll never get a better perspective than hearing from somebody who's going or who has gone through the experience of a lung transplant. So I think we'll make a good team today and hopefully cover some really important ground today. So we're going to talk about lung transplant in 2025, and we're going to review it really in the context of pulmonary fibrosis. And really, I wanted to focus today really a lot on the process of lung transplant, really from the perspective of someone who has either been newly diagnosed or is dealing with having pulmonary fibrosis, and some things to think about in terms of being referred, but also going through the process and in some way what life is like after receiving a transplant as well. And we're so lucky to have Mark join us today, who can provide his perspective, and we're happy, I think, to answer any questions that you might have about any part of this process. So this, as a brief introduction, and this is nothing new to I think probably most people who will be watching this, is really what are we talking about when we're talking about interstitial lung disease? And this obviously encompasses a large number of different specific diagnoses, but really the core of the problem is the same. And that's where there's either abnormal inflammation and or fibrosis that's causing a disruption of the normal architecture of the lung. The scaffold or that connective tissue that helps our lungs be so flexible and provide the elegant structure becomes very abnormal, and they become very stiff, and that can cause you to become very short of breath, and also importantly give oxygen a very difficult time to diffuse across into from your alveoli into your capillaries and provide that critical oxygen to your body that it needs to function on a day-to-day basis. And as we know, treatment options while growing are limited for pulmonary fibrosis, and it's an inevitably progressive disease despite really all the treatment options that we have to date. What is the treatment for ILD? This is a slide that says IPF, but I think a lot of these, and I think it really nicely highlights really how multifactorial or how many different considerations there are when thinking about interstitial lung disease. We often spend a lot of time in clinic talking about medications, which you can see on the top, but there are many, many other things that we cover as well, from oxygen therapy to proper nutrition, talking about smoking cessation if appropriate, managing other health issues. And then on the right here, which is really going to be the focus of our discussion today, is really talking about the timeliness of transplant. And it really will be from your ILD physician where you're going to receive that consideration and referral for transplantation. So, looking at the global community, as you can see, so we have a very nice international database that's been on pause for a little while, but historically we've had very robust data collection. And you can see that worldwide, the number of lung transplants has been growing very, very quickly since the procedure was first widely adopted in the 1980s. And you can see that, towards 2016, 2017, we were really approaching sort of 4,500 lung transplants across the world. In the context of this discussion today, interstitial lung disease is now the #1 indication for patients being referred for and receiving lung transplantation. In the earlier days, there was a much different spread from things like COPD and cystic fibrosis, whereas now patients with pulmonary fibrosis, unfortunately, make up the lion's share of those patients undergoing lung transplantation. I'm a member of the Toronto Lung Transplant Program, and this is our own data, and really it's current actually up until last month of this year. And you can see that, similar to the global trends, the number of lung transplants in Toronto have been rapidly increasing sort of over the last, in the 2000s and 2010s. And then now in the sort of last 5 to 6 years, this small dip related to COVID aside, we've been doing over 200 lung transplants a year and are on track to do the same number again this year, making us the largest volume lung transplant program in the world. So let's talk about let's break it down a little bit. So who is a good candidate for lung transplant? And I think there's a number of considerations that are very important in that regard. I think first, and there's some nuance to this, you need to be sick enough to be considered for a lung transplant. And of course, having previously explored other interventions that might be available for your disease. But we're very often referred people with advanced disease with a significant symptom burden and have, functional impairment, require supplemental oxygen, and we're concerned about, the burden of their symptoms and of course, survival as well. We need our recipients to be able to benefit from a lung transplant. And by that, I mean that they don't have any other major diseases which could also cause a significant impact on their health. There are many examples of this, but a very advanced cancer, for example, would be a major concern when thinking about transplant and whether or not you'd be able to benefit from what can be a very intense procedure. We also need people to be able to undergo rehabilitation or, pulmonary rehabilitation or exercise and other things, both before and after transplant, to be able to derive the maximum benefit. We need to be able to have people optimize themselves for surgery. So for example, smoking cessation is a very important part of this process. Being able to target an optimal weight. We have very good data to show that when we have weights within our target BMI of somewhere between 18 to 30 or 18 to 27, we really see the best outcomes after transplant. And as hopefully you'll learn from today, or you may already know, it's a very, very onerous process, and it really requires recipients to be very well supported to sort of get their heads around what could be a very complex medication regimen, attend lots of clinic visits, and of course have adequate supports from either family or friends or a combination of those two. So when to consider referral for transplant, or when should you start thinking about this in combination with your specialist? And these are, again, it's not an exhaustive list, but these are very common things to think about when thinking about a time of referral for transplant. So PFTs, or pulmonary function tests, as you know, are the major way that we both assess the severity and monitor the progression of interstitial lung disease. And severely abnormal PFTs, so a very low vital capacity or a diffusing capacity for carbon monoxide, would be indicators that we should consider referral for transplantation. Or similarly, if there's a significant decline in PFTs, so if you're on your follow-up visits, your forced vital capacity is declining, despite any intervention, certainly would raise a flag that transplant should be considered. A significant amount of supplemental oxygen, so a new oxygen start, I think, is definitely a sort of very much a major sort of shift in someone's disease. But if those oxygen needs are climbing and becoming quite significant, that would be a time to consider transplant. The development of pulmonary hypertension, which means very high blood pressure within the lungs themselves. And this is most often detected on echocardiography or an echocardiogram, would be an indicator that transplant should be thought about. Or if there's a very high burden of symptoms related to the lung disease, so shortness of breath, cough, and of course, hypoxia as well. There are some other more nuanced considerations. So if you have a strong family history of interstitial lung disease and you've been diagnosed with pulmonary fibrosis yourself, we do know that these disease types tend to behave a little bit more unpredictably than other diagnoses, and we often advocate for early referral in that situation. If you've been recently admitted to hospital for a complication of your lung disease, so either an acute exacerbation or major infection, that also often represents a major change in the behavior of your disease, and it may be time to think about transplant referral in discussion with your respirologist. And then there are other more rare specific subtypes of interstitial lung disease, some of the inflammatory myositis, for example, that we know have a very rapid disease course, and we often again advocate for early referral for transplant in that situation. I will say it's never too early to ask the question. Almost all of my colleagues really across the country are very familiar with transplant, and I would say probably are very happy to at least start a discussion about it and maybe refer you to some online or printed educational materials. So it's never really too early to ask the question if you've been diagnosed with ILD, but I think very important to discuss with your respirologist when the best time to be referred to a program would be. So I think I've sort of phrased 4 big questions here that I think encompass a lot of the sort of common questions that come up when thinking about or talking to patients about lung transplant. So those are, first, why is it such a big deal? Second is, where does the process start and what does the process look like? Third, what does it mean to be listed for transplant? And then lastly, what will my new life look like after receiving a transplant? And I won't be able to cover every possible facet of these questions, but I'm hopefully provide enough of an overview to really create enough of a foundation to have a more meaningful discussion. So why is it such a big deal? Well, first and foremost, there are not enough lungs to go around. And that's just a crude way of saying that we really struggle to find enough donor organs for all of our recipients on the wait list. Most programs around the world work really, really hard to keep what they call their wait list mortality low. So for every patient we list for transplant, our #1 goal is to get that patient through a successful lung transplant. But we rely very heavily, or we rely completely on having donor organs available, and we have no control over that whatsoever. And so it's an important thing to think about when going through this process. Lung transplant places a very heavy demand on patients and their families. Not only are you dealing with an advanced and significant illness, but as I'll hopefully highlight today, going through the process of an assessment for transplant is a very involved and time-committed process. And then life after transplant is very, very busy as well. So it really places a huge demand on the recipient, and of course their support team and loved ones as well. Lung transplants eventually stop working, and I'm going to talk about that in a little bit more detail later. And I tell people that it's important to think about receiving a transplant as a trade. You're trading one disease for another. So you have a very advanced lung disease, which causes a very high burden of symptoms and will ultimately limit your life expectancy. And you're trading for another disease, although a disease that will hopefully give you a much better quality of life and a much better survival, but it does come with a lot of potential complications and a lot of responsibilities as well. So again, important thing to think about when talking about this process. So what does lung transplant look like? This is a very busy slide, and we don't need to go through it all in detail, but as you move from one end of the slide to the arrow on the other, kind of shows as you move through from being referred to ultimately receiving a transplant, there are many pit stops along the way of this journey. And I'm going to try and break these down a little bit more. But as you can see, there's a lot involved in going through sort of an assessment and getting things done, and of course, moving through the actual surgery itself. So here's how it all starts. And it really starts, at least from my perspective, with a referral to a transplant program. So you'll be identified as having a disease or some kind of change that your respirologist is concerned about, and they think that you need to see us in the transplant team. Now, again, I'm speaking as a member of the Toronto program, and I think a lot of our practices are very similar across the country. There is obviously some nuance depending on where you live and which program you interact with, but I think that these sort of in general are probably quite accurate to apply across different programs. But from time of referral to time being seen, of course, depends on what's happening with your situation. So if you're very, very unwell and your respirologist is very worried, we can see you very quickly, often within 1 or 2 weeks if you're very, very sick. In our program, on average, our referrals to consultation take somewhere between the order of 2 to 8 weeks to be booked to be seen. So pretty quick. And we appreciate that. Obviously, being asked about transplant is a time-sensitive request. So you'll be referred to our program, and we'll do an intake assessment with your chart, and then you'll be booked in to see either myself or one of my colleagues, and you'll have a consultation where we get to know you a little better, ask lots of questions, review your testing available, and we talk about what next steps might look like. If we think the time is appropriate and you're interested, we'll move forward with what we call an assessment. And that's, I'll talk about in more detail in a little bit. We do a whole battery of tests and other appointments to really, as I sort of give the analogy of looking under the hood of a car, to really understand what makes your engine run, what problems there might be, and really just getting to know you as well as we can to really figure out what your transplant candidacy might be. Again, the time it takes to do an assessment is very dependent on this, your situation. But on average, for our patients referred on a routine basis, an assessment takes around 3 months to get everything done. Once an assessment is completed, we sit down as a group in Toronto once a week, and we review a certain number of our potential candidates to go over all of their testing, and we discuss whether or not they'd be a candidate or not, and what next steps should look like. So, we're a national, it's a national foundation. We're a group across the country. It's a very big country geographically, and there are a number of programs that serve what is a very geographically diverse population. So moving from left to right, there are lung transplant programs located in Vancouver. There's a surgical program in Edmonton, and then a partner medical program in Calgary. We have another program in Toronto, and then there's another lung transplant program in Montreal. So depending on your geographic location of residence, you would be affiliated with one of these specific programs where you would be referred for your assessment, potentially a transplant, and then of course your post-transplant care as well. So to move back to what an assessment is, so you've had your consultation done, and what does the next step look like? As I alluded to before, this involves pretty extensive testing where we really want to get an understanding of what's going on with you and your body. We partner very closely with your referring respirologist and your family doctor, and we do our best to arrange most testing as close to home as we can. And really think about this as an overall evaluation of your health. So we like to understand what your heart function is like, of course, what your lung function is looking like, your kidney function, if there's any liver problems, a whole series of different things to really understand what your health is like in general. It's more than just tests. You have the opportunity to meet with other members of our team as well. So for example, our physiotherapy team, so occupational and physiotherapists, dietitian, social worker, anesthesiologist. So there's a whole different number of assessments that you'll have with different members of our team. And it's very nice because we get to learn more about you, but you also get to learn more about us. And lots of different facets of the transplant process are communicated throughout this process. And people say it is quite an informative experience. So once we have the assessment done, we move on to our assessment meeting. And this is really a very extensive multidisciplinary discussion where, I and my colleagues in transplant respirology will sit down with thoracic surgeons, anesthesiologists, and all those other members of the allied health team that I alluded to before. And we have a very rigorous presentation of each person that we're assessing. We go through. And what we do is we determine whether you're a candidate or not, if there are certain modifiable risk factors we need to address, and whether the time is right to move ahead with listing for transplant or not. And I lay this out graphically in a few slides, which hopefully will help it make a little more sense. And here it is. So as we looked at before, really it starts at referral and then moves through assessment. And then there are two possible outcomes. We either determine that you're eligible or that you're not eligible. And it may be that you're not eligible, but there may be some things we could modify to sort of, whether you have, heart disease or something else that we need to work on to make you then eligible. If you're eligible as a potential recipient, it may be that you're still too healthy to proceed with transplant. So we appreciate you have a lung disease, but there may be some treatments available, or we may need to hold on for a little while. And you then go into our sort of follow-up protocol where we'll see you periodically to assess the state of your health and try and determine the best time to move forward with the listing. Once you are determined eligible and it's an appropriate time to move ahead, then we move ahead with listing. And that means you meet one of our surgical colleagues to really talk in detail about the operation itself. You sign a number of consent forms and talk about other facets of the program. And then you would be what we call actively listed for lung transplant. And I'll talk about that in a little more detail as well. And then sort of what things look like when you move from listing through to your transplant surgery specifically. So what does it mean to be listed? So in Toronto, we really require people to be within reasonable proximity of our program. And now there's been some evolution in our technology that you can live somewhere around 5 hours away while waiting for your offer to come through, which has been very nice for people who live, close but not close enough, historically speaking. Those who live further than 5 hours away, we do still require to relocate to be closer to the program. Transplant is a very time-sensitive issue, so we really do need people to be able to make it in a reasonable time when an unexpected offer might come through. We, of course, require people to stay as healthy as possible. Of course, smoking cessation is a critical part of this process, but we do also require people to regularly engage in pulmonary respiratory rehabilitation, either with their local program, with periodic check-ins with our rehab team as well. And of course, we need to be able to reach you. As when you're on the wait list, an offer can come through at any time. Patients used to carry around pagers, but now we of course have, with ubiquitous cell phones, we can give you a phone call, but we obviously require people to be contactable. People will very often ask, how long will I wait once I'm on the list? Again, this is quite variable by center. In Toronto, our average wait time is somewhere around 6 months. That ebbs and flows depending on how things are going. But it can be as short as a couple of days or can be long as a couple of years, depending on sort of a number of factors. And if there are questions about that, I'm happy to try and address those. But the wait time can be quite variable with an average of around 6 months or so. So let's say you're on the wait list and your phone rings and you're called in for surgery. So what is life like with new lungs? And we're going to go through the good, the bad, and the ugly. And the ugly I just put in as a catchphrase, but again, it's important to sort of think about all different parts of this process and what you can and cannot expect. So you go through your surgery, you're called in, and what does recovery look like? On average, if things go really, really well, most of our recipients are in the hospital for about 2 to 2.5 weeks after their operation. Like any major surgery, there can be complications related to the operation or your new medications or other issues, so that stay can be extended. Everybody starts in our intensive care unit to recover from the operation, and then as you progress to further recovery, you get to move down to our step-down units and then our general ward. We get you back up on your feet, used to all your new medications, and hopefully get you out of the hospital, as I said, within sort of 2 or 2.5 weeks to start your new life. Most, if not almost all of our patients no longer need oxygen when they leave the hospital. So you bring your tanks in when you come and you get to leave them behind you when you leave. And at 3 to 6 months after transplant, we really hope to have you sort of back at your own home for those who have had to relocate and really as close to back as living a normal life as possible. We typically tell people it takes about a year to really fully settle into your peak lung function and get used to everything. But really, we see people doing very, very well if everything goes to plan, sort of 3 to 6 months after they receive the operation. As you can imagine, this is a big undertaking. It does come with some challenges. It's important to note that life will never be the same. You've gone through something as significant as having your organs replaced. So it really does mean a big difference, but I think a very important one. There are lots of clinic appointments, and these are really front loaded in the first few months after transplant. And of course, this places a big demand not only on you as a recipient, but of course your family and support network as well. We typically see our patients every week, really after their first discharge. As things are going better and better, we kind of go to every other week and then every month, et cetera, et cetera. So we really start to stretch out the visits as you recover more and more, but it's really very busy in the early post-operative period. Mark can attest to this, but there are lots and lots of tests that we like to do. We love drawing blood. We love sending you for x-rays and CT scans. We do lots and lots of breathing tests. We're starting to use home spirometry a lot more now as a very helpful adjunct to doing in-lab spirometry or PFTs. So you'll have a little spirometer that you use at home, and we can track those numbers, which is very useful to assess your healing and your wellness. And really the key for these is to monitor the health of your lungs and really be vigilant or surveil for any potential problems coming down the road. There are also lots of medications that we use after transplant as well. The core of these are 3 immunosuppressive drugs that you'll be on for the rest of your life. And I have a little bit of detail about those in a following slide. These medications come with lots of side effects, and they do add up over time. Most of what we see are really related to your metabolic system. So we see a lot of things like damage to the kidneys in the long term. Our medications can cause high blood pressure or problems with your lipids or cholesterol. We often see diabetes and obviously a higher risk for infections because we're suppressing your immune system as well. The risk of cancer, unfortunately, is also increased after you receive a transplant and are on immunosuppression. The most common cancers we see are skin cancers, so things like basal and squamous cell carcinoma. So we really advise our patients to be very vigilant about appropriate sun protection and, very importantly, getting their skin looked at once a year by either their family doctor if they're comfortable or by a dermatologist to make sure that they're getting appropriate surveillance. And lastly, I'll talk about this in some detail in a minute as well, but we always are concerned and surveilling for the onset of what we call chronic lung allograft dysfunction, or CLAD for short. And this is what we call, this is the sort of term for chronic rejection of the lungs, which is almost inevitable. And unfortunately, the lungs, this is the major cause of morbidity and mortality in our recipients. And eventually those transplanted lungs just don't work as well as they did when we first transplanted them. There's some detail here, and again, you're welcome to go to our program website. We have a lot of detailed information you can look up, but these are sort of the core immunosuppressants that we use for patients who have received a lung transplant. So there are 3 different kinds of drugs that we use. The first is a calcineurin inhibitor, and there's 2 of these that are available, cyclosporin and tacrolimus. There's been a lot of recent evidence to support the use of tacrolimus, and we're really using this much, much more frequently. So you won't really see much cyclosporin being used anymore unless you've had your transplant some time ago. Cell cycle inhibitors like azathioprine or mycophenolate, and for those of you with some forms of interstitial lung disease, these will not be unfamiliar drugs that may be used for your ILD. We use those in transplant as well. And then everybody's best friend, prednisone, is another drug that we use, and you'll be on prednisone lifelong after you receive a transplant. We start with very, very high doses at the beginning and try to taper those down as quickly and safely as possible to the lowest possible dose for the long term. But it will be a drug that's part of your combination for the rest of your life after receiving a lung transplant. So this is a slide, again, this is from our ISHLT database that shows the onset of chronic lung allograft dysfunction, or what's also known as chronic rejection. I'd just like you to focus on the blue curve here, and this shows the onset of this clad over time. And you can see, as you look at the y-axis on the left here, 50% of our recipients develop measurable chronic rejection about 5 years after they receive their transplant. And you can see that as time goes on, it becomes more and more and more frequent. So unfortunately, this is the body sort of generating a chronic form of rejection to the lung and really slow damage to that graft over time. And despite all of our drugs and monitoring, we haven't found a way yet to prevent this completely. And so it's a major concern. And as I mentioned before, the #1 driver of mortality in our recipients after lung transplantation. A very common question again is about survival after lung transplant. And we're happy to say that this has been improving a little bit over time as we get better experienced and have a more sort of sophisticated approach of managing and monitoring our lung transplant recipients. A little bit of a busy slide again here. This is a survival curve. So you'll see on the y-axis or the left here is the percent of recipients still alive. So as you go down towards the bottom here, the number of people living drops off, and then time on the x-axis. So as you move from left to right, the number of years pass by. You'll see that at the beginning here, and then there's two curves here. So the dotted line are those patients who have undergone a bilateral or double lung transplant, and the solid line are those patients who underwent a single lung transplant. Now, this is a very complicated discussion when talking about single versus double lung transplant. I'm very happy to answer if anyone has any specific questions, but I'll try and at least address it a little bit in the context of this slide. So again, if you look at the left, for both curves, you'll see there's a very quick drop off early here. And so there's a definite change in survival really in the first couple of months after transplant. And I think this is mostly reflected by those people who are very, very sick coming into their transplant. So people who have developed either a very acute worsening of their disease or are very, very critically ill at the onset of transplant, or those who have very severe complications. There's a very early change in survival after transplant. But as you can see, as time goes on, there's a slow and steady slope to the curve. 50% survival is an important statistic that we quote. And as you can see here, for a double lung transplant, around 7.5 or 7 to 8 years is sort of our median survival, or about 50% of patients are still alive. If you look at single lung transplant alone, it's lower, of course, around 5 years. So when you look at the absolute difference between these two, there is a difference. But there's a lot of sort of nuance to this. It's not adjusted data. Generally speaking, we typically choose single lung transplant for older recipients, although that's not universally true. So it's a little bit difficult to compare these curves head to head, but if you do look at raw unadjusted data, there is definitely a survival difference between single and double lung transplant, but a bit of a nuanced conversation. You'll see this number that says conditional survival here. This means if you survive out of the first year, so if you survive to 12 months, then your conditional survival increases to 10 years or 6.5 for double and single lung transplant, respectively. So to summarize then what I've covered today, so lung transplant is a complex process that requires initially referral, and then assessment, and then of course preparation for both listing and then the transplant itself. Life after lung transplant is busy and complicated with many new medications and responsibilities, but really is a very powerful way to have a significant impact on someone's quality of life and survival as well. As I alluded to previously, 1 year survival is somewhere around 90%, and then the median survival is somewhere between 5 to 7 years, again, depending on the circumstance and what operation is chosen. And I think I would finish by saying for the right patient at the right time, lung transplant can provide significant improvements, again, to quality of life and survival. So again, I really appreciate the opportunity to go over this. There's a lot of nuance and a lot of detail involved in transplant, and most people I talk to about this for the first time leave very overwhelmed. So I will, there's a lot of high quality resources, not least of which are available on the CPFF website. So I really encourage people to read, write things down. You know how it goes whenever you show up to your doctor's office, all those amazing questions you had just go out your ear as you walk in the door. I will say that I and my colleagues are happy to answer questions at any time about this. And don't worry if it seems overwhelming. I think that's probably the universal experience. But the more you learn about this, the more empowered you'll be to ask better questions.
I was going to say, Dr. Scallan, thank you very much for that presentation and answered quite a few questions. And now I'm going to ask Mark Ashcroft to share his journey with his experience having received a double lung transplant. So Mark, the floor is yours.
Thank you. Just a little bit of background. I'll try and be quick here. I do have a family history. 3 brothers have had the disease. 1 passed away and 2 of us have had transplants. our transplant journeys are very different. I was relatively healthy when I got my transplant. Things went well quickly for me. I was home in no time. My older brother was quite a bit sicker than I was, and a month in the hospital pre-transplant and 6 months post. So totally different journeys. In 2018, I got the chronic cough. I was referred to a respirologist right away and told I had ILD. I didn't ask, but I sort of knew it was pulmonary fibrosis. Everything went fine. I was tested regularly. In 2021, I'd been on OFEV for about 8 months, and I had an exacerbation. At that point, probably lost 50% of my lung capacity in 2 months. My local respirologist referred me to UHN for a transplant. I would say it was about 6 weeks. I met with a doctor. My wife and I did it virtually, and they explained everything. They don't hold anything back in that initial meeting, tell you the good, the bad, the ugly, what to expect, and then you can make a decision whether you want to go on with the testing or not. You're not signing any paper or anything at that point. It's just, do you think something you'd be interested in? So that was it. We don't, but I have a family history of colon cancer, and I had precancerous polyps removed a few years before. So they're just covering all the bases and made sure that that wasn't going to be a problem. Listed in June of 2022, I had 2 dry runs. For those who don't know what that is, that's when you get called in for a transplant, and for whatever reason, it doesn't take place and you get sent home. The first one, the lungs just weren't suitable. And the second one, a few months later, I tested positive for COVID. So they couldn't do it. In January of 23, so I was on the list 6 months, I got my transplant. I had been working very hard in a rehab program and was in pretty good shape. And I was home in 10 days, which is pretty amazing. I was feeling great. At 1 month, I was sitting on the couch. My wife went out shopping, left me alone for the first time. I walked to the washroom, came back, and I couldn't breathe. My SATs were down to 82. Luckily, my oxygen supplier told me to keep the oxygen for 6 months. So I put that on, got the oxygen levels back up. Being an hour away, we went straight to Toronto Gen. That night in Emerge, I saw respirologists from the transplant team, had my CAT scan with contrast, knew I was into a major rejection, and was admitted. So fortunately for me, I was very close. I ended up being in 19 days for the rejection. All the treatments, everything went well, and I've had no problems with that since. So amazing at what they could do. Couple of things. I did pick up a CMV infection, which is a herpes type infection, very common in the general public, but I picked it up through the transplant. And once it became active, we had a real hard time getting it under control. It took about 1.5 years. The meds for it were sending my blood work wonky. When they reduced the meds for it, it came back, and it was just that fine line. We finally got it under control. The only other real thing that I've had this fall, I picked up a viral infection of some sort, never really diagnosed, but it took me almost 7 weeks to get over it, just because my immune system's so suppressed. So you really do have to be careful on what you're doing, because things like the public, probably a week would have been better. I was 7 weeks. So the only other thing that I've had is recently diagnosed with a cataract, and they're pretty sure it was the prednisone that caused that. So, but that's not a big deal. I can get that taken care of. I have an appointment already to see the doctor. Overall, I got to say, yeah, there's a lot of appointments. Locally, I do blood work every week because I do have issues with that. Once a month, I do my pulmonary function. And I still have to go into the hospital once in a while, but not too often. I'm feeling wonderful. Life is good. I can't do everything I did before, but I can do most things. I play softball in the summer. I curl in the winter. This year, we had some yard work to do. It took me 3 days to do it instead of 1. Well, big deal. I still got it done. So I would say life is wonderful and well worth it. The quality is definitely improved since the transplant. Couple of comments on the slides. The one slide said sick enough. Yeah, I wasn't as sick as a lot of people, and I almost feel like I jumped the queue. But you're ranked. I was the lowest ranking of 1, and luckily, the lungs were a match for me and nobody else. So I didn't steal them from somebody who was sicker. It's just nobody else matched above me. So I don't know how sick you need to be, because for me, I was fairly healthy except for my lungs, and it sure aided in my recovery. And so did the pulmonary rehab, because I was able to be in pretty good shape. For the referral, for me, I think it was the exacerbation for the most part, because I certainly wasn't as sick as most people. I was on 4 liters of oxygen on exertion. In the house, if I was walking around the house, I didn't need it. If I went up the stairs, obviously I needed it. The oxygen, my carrier did say keep it for 6 months, and I'm glad they did, because I used it at my rejection. And one time when I came home from a bronchoscopy, I think it was about 6 months, they kept me a little longer because my O2 levels weren't coming back up quickly. On the way home, I started to vomit. Got home, felt horrible. Put the oxygen on, had a nap, woke up 3 or 4 hours later, and I was fine. So it's handy to have that for a few months, because you just don't know if you're going to need it. I think I already touched on locally. I'm able to go for blood work every week and a pulmonary function once a month. Talked about home spirometry readings. Daily, I do my spirometer and my vitals, and once a week I submit it to the team so they can have a look at it. Got a lot of doctors now besides the respirologist. Because of my CMV, I have a infectious disease doctor. Because of blood work, I have a hematologist. Because of skin issues and looking for skin cancers, I got a dermatologist. So a lot of doctors, a lot of appointments, but the trade-off is well worth it, and I'm loving life. So I think that's about all for me.
Thanks for sharing that, Mark. That's really nice to hear your story, and I think thanks for sharing that about your family as well. I think I think it highlights not only the importance of understanding that you've got a family history of lung disease or lung fibrosis, but how different the experience can be. Even for brothers in the same family, things can go very differently. If I could ask you a couple of questions about your experience, Mark, and it might be a little tough to reflect back. Is there anything about the sort of process before you went through your transplant that you think you should have done differently, or could have been done differently, or that you really, really wanted to know or should have asked before you went through things?
I wish I'd known about dry runs. The first one, I had no idea. I thought, this is it. We called everybody. And then the next day, you got to call them back and say, it didn't happen. That was for me the one thing. But I thought, even in the initial intake interview, the doctor just explained everything so well. And my wife has been at every appointment, and that was good, because then it wasn't my interpretation that she was hearing. She heard it right from the doctor. So, yeah, I thought it was so well explained that we didn't have any real questions.
That's great. You're lucky to have seen somebody, obviously, who was very descriptive about things. So I do 2 things quickly. I guess the dry run thing, you're right, it's very challenging, and people get it's hard to sort of get yourself really amped up and really prepared for something like a transplant, only to hear that it's been canceled. And just to explain from our side, so we get offers of organs from all over the place, and we never really know what they're going to be like until we can go see them. and we have to start the machine of transplant moving before we really know. And so we'll obviously activate and get everybody ready, but what we really want to do is only use the best possible lungs for our recipients. I tell everybody one dry run is great because you know where to go, you know how it works, you know what to do. It does happen multiple times to people, and it can be tough. Even the phone ringing when you're on the wait list can be tough because every time it rings, you wonder if it's a call. So we don't minimize, all those challenges that can be there.
Well, I did learn after the first one to take a few things with me because it's pretty boring in that room, and you're really not a patient yet. So the nurse assigned you checks in once in a while, but you're in there for 12, 14 hours basically with nothing to do. So you better bring something to do.
Yeah, a couple of good books or an iPad or both, maybe.
Exactly.
Yeah, very good. I will say too that if you don't have Mark's experience and you find yourself with lots of questions, I alluded to it before, but there's lots of good resources available online. Hopefully, our discussion today may provide some insight for some people. But there are also, most of the transplant programs have manuals available where a lot of these things, especially things like medications and what does a bronchoscopy look like, or when do we do them? A lot of this stuff is written down, so you can go and take a look at those manuals and print them out and really get to understand what a lot of the sort of lingo and terminology and other details are available. And again, your respirologist would be very happy to go over any of those in the clinic if you bring that in with you.
So Dr. Scallan, there's a couple of questions that people have asked me to ask you. Sure. You mentioned that there are 5 centers across the country that do lung transplant, but many people say that each of them have a varying differences about what age level they'll accept you at and their criteria. Like, why is that? Why isn't it the same standard across the country?
Yeah, that's a great question, Ciaran. And I will say it's not just Canada, it's really across the world. There really is no standardized acceptance criteria for any solid organ transplant program. And that's really because, it's a very nuanced and complicated undertaking. And it really relies very heavily on the experience of the center. Obviously, those people working in the center, how well they're resourced. So it really is a very center-specific decision on which patients they'll accept for eligibility for listing and ultimately transplant. So I think each center across the country has a different set of criteria that they've established. The other challenge is that, there are these lists that are published, but, people are complicated and life is complicated. So there are often there's lots of nuance to these decisions, and really it becomes very personalized, which it really should be. So, for sure, there are definitely different criteria depending on where you live and which program you interface with. But I think there's very important reasons for those.
Okay. And someone wanted to know, if they don't qualify at their center, how can they get their doctor to advocate that they get onto another center's program that might accept them? Like, how does that work?
Yeah, another great question. So I think it's really important to speak to the team, either your respirologist or if you've seen a transplant respirologist, to ask that question. I think, you can think about it like a second opinion. Those are very common in really all parts of medicine if you want to, have a different perspective on your disease. So I would encourage you to speak to either your primary respirologist or your transplant respirologist. If you've gone through the assessment and have been declined at your local center, I think you're fully within your rights to ask for another opinion, but the vehicle would be through either, as I said before, your respirologist or the transplant program you've worked with.
Okay. Someone said that Mark had stated that, he was relatively healthy. Some folks feel like their doctor say, well, you're not sick enough. And they're quite worried. Like, when you get to be that sick, are you going to be strong enough to go through this long, arduous surgery and to be able to recover? Like, how do you advocate for yourself to say, look, I don't want to be sick enough, so sick that I can't get it anymore, but I don't want to be healthy enough that, not, to get in the line. But as Mark said, he wasn't jumping the queue. He was just saying, well, this is the one that fit him the best. It didn't fit anybody else. So it wasn't like he was trying to get someone else's lungs.
Yeah, absolutely. So I guess there's 2 parts to that question. So the first part is, how do you advocate for yourself? So I think certainly asking the question of your specialist is really, really important. I think Mark's a great example of, we really want people to be sick enough, so, have enough or advanced enough disease to really benefit from receiving a transplant. And the important thing to remember there is that, as we talked about in the presentation, life expectancy after a transplant is not normal. Now, I just presented statistics, and that's important to remember that obviously, different people have different disease courses or different, different survivals. But we really don't want to do transplant too early, because there really is a sort of a clock that kind of starts once you receive your transplant, if you look at the statistics in and of themselves. So we really need people to have severe enough disease to really benefit from a transplant. But again, just like Mark, who went through rehab and was really fit and strong, and as you heard, really sailed through his operation, we don't want people to be sort of really, really unwell and not strong enough to get through that transplant.
Okay.
So there is a bit of an art to it as well. So I think you have to ask the question of your specialist and say, look, I went to a presentation, or I read about this online, and I'm using oxygen now. Like, maybe this is a good time for me to be talked to you about transplant. Again, there's only so many of us who see patients for transplant consultation, but especially for patients with pulmonary fibrosis. And if you're on oxygen or you've been in the hospital, these are always reasons that we're more than happy to see people in consultation and to talk about lung transplant.
Okay. Several women wanted to know, they feel very frustrated. It seems like there's a longer wait for women, and they're told it's because due to their lung cavity size. So can you explain a little bit more about that? Like, how can we sort of advocate for them? And are there different methods? Because someone had said there's a new method now that you just get the lower lobes of the lungs for women. Can you explain a little bit more about that?
Sure. Thanks, Ciaran. So yeah, another sort of multi-layered question. So you're very right that this is a growing problem. I think we're appreciating in the community, and we're very aware of it. So there are basically so there are many things we look at to match the right organ to the right recipient. The sort of two biggest ones are how big you are, so your chest size, and that's really determined ultimately by your height. There are a few other things that play into that as well. So if you have a shorter stature, by nature, your chest is going to be smaller. And then the other issue is your blood type. So there are certain blood types that are a bit easier to match and certain blood types that are more difficult. But you're right, for sort of shorter stature individuals with a smaller chest size, we often find that the number of organs that come through, especially of a smaller size, are less common. And so by nature, people with smaller chest sizes are going to have a lower chance at receiving a successful offer for every organ that comes through. There have been a number of ways that have proposed to try and mitigate that disadvantage. As Mark alluded to before, there's a sort of priority or a wait list system that we have, and we really do that based on, the severity of someone's illness is really the number one criteria. We just don't want anybody to die while waiting, and so that's a really important motivator for us. But we're starting to develop a different way of thinking about, well, do we have to think about other things as well? So if you're someone who's waited for a long time, for example, if you've been on the wait list for a long time, we need to take that very seriously. Or if you're someone who has a certain disadvantage, so a certain blood type or a certain size that we know is going to be very difficult to find, are there ways that we can provide a more sophisticated analysis of our offers to provide that recipient with a better chance of a successful transplant? There are sort of different allocation systems that are in place throughout the world, and we're constantly evaluating how we're doing this. But I think ultimately we're really victims of not being able to control what offers we receive. Now there's lots of work going into sort of bioengineering of lungs, so trying to make donor lungs like blood type neutral. I mean, these are things that are not going to be in clinical practice anytime soon. But I think the community really realizes that these are very important problems that we really need to address. So there's more sophisticated allocation systems, things like bioengineering. These are very important sort of ways that we're trying to attack the problem, but we do appreciate that it's a big issue. To your final part of the question about lobar transplants. So this is, as you very accurately said, Ciaran, where not the entire lung is transplanted, but a sort of section of the lung or just a lobe is transplanted into a recipient. And that's certainly a possibility. But I don't think it's something that we would adopt as a universal practice. There are certain challenges that come with receiving a lobar transplant from an anatomic and surgical technique perspective. It's very possible to do, but we do see there are some challenges associated with receiving a lobar transplant. And if we had the choice, we certainly would prefer to do a whole lung transplant in that situation. I guess, we'll have to see how things evolve. If we find more and more people are being more disadvantaged by things like size, that's something we may have to look into doing more, but certainly our preference would be to do like a proper full lung transplant if at all possible.
Mark, do you have anything you want to add to that?
Yeah, I just have noticed I get the monthly newsletter, and the wait list is certainly a lot longer now than it was when I went through 3 years ago. It was about 70, I think, at that time. And I think I saw the other day it's 110. So it's significantly larger. So that will affect it too.
Yeah, that's a great point, Mark. And I think part of that is maybe coming out of COVID, right? There's a lot of people that have, there was obviously COVID just totally disrupted everything we do. I think we're being, we're seeing our referral volumes are going up, and I think that's true across the country. People are sicker. We're diagnosing this more, which is wonderful. A whole other, we're picking up ILD more than we ever were, which is really, really important as well. I will say importantly, though, our wait list mortality has not really changed, despite having a bigger wait list and more people all the time. Mortality is just one indicator, but I think we're working really hard to make sure that stays the same. But you're absolutely right. I think, there's just more of everything these days, and we're doing our best to keep up, but that's a very important thing to keep in mind.
So, Dr. Scallan, someone wanted to ask you, they were really shocked that a doctor who graduated 40 years ago would still actually understand all the medication that a lung transplant patient is on, because the rejection drugs hasn't really changed. And someone wanted to know, with all our advancement and everything, surely someone has been able to create something with less side effects or better effectiveness than what we gave out 40 years ago. Yeah,
that's also a great point. Just something being older doesn't necessarily make it inferior. I will say that things like cyclosporin and tacrolimus were absolutely revolutionary. I mean, organ transplant wouldn't be possible without those drugs. But you're right, they do come with lots of side effects. I'm sure Mark can attest, especially to prednisone. You mentioned cataracts as one example. It's just, it's not a drug that's great to take, but we have to use it. And there are new drugs that are being studied. Like any new medication, looking at things like nerandomilast, right, and the use of in interstitial lung disease, from conception to putting into practice takes many, many years, a lot of hard work, commitment from many different people involved. I think the challenge with transplant is that it's a very different problem. People present in different ways. The biology is very different. So it's been very challenging to have a universal or a single drug that works very, very well in different people. But there are a lot of randomized controlled trials going on now with drugs that are being used in clinical studies. And in particular, we're trying to reduce the progression or development of CLAD, or that chronic rejection that I alluded to. That's our major, major problem in lung transplant right now. So you're right. We need newer and more drugs, and it's not from lack of desire. And I think the horizon is very bright. Just like in ILD, the horizon in transplant is really promising with a lot of potential new medications. So I would say, hold tight. I think there's definitely going to be a lot of exciting things in the sort of next 5 to 10 years.
Okay. Someone wanted to ask as well, what about cloning? They've heard a lot about, how you can take your cells and grow it into your own lungs, or even the xenotype where we have a genetically modified pig that has your DNA, and their set of lungs are basically your lungs. How far do you think we're away from actually seeing that to fruition, so that you actually get transplanted with your own lungs, basically?
Yeah, that's a really exciting question too. I didn't really talk about that in this presentation, but so xenotransplantation, so that's the term that applies to transplanting sort of non-human organs into human recipients. And I'm sure you've read in the news about, kidneys mostly have been at the forefront of this. So there's definitely been some work in lung in that regard. Lung transplant's really tricky. The problem with lungs is that they're the only organ that are exposed to the environment, right? When you breathe in air, your lungs are exposed to air, and no other organ in the body other than the skin, I suppose, really have that condition. And that's why we struggle so much in lungs. So you're breathing in things all the time, and it really sort of makes your immune system very primed. And so it's really provided a lot of challenge for us in the lung transplant world when it comes to different technologies. I think more promising probably is genetic modification of donated organs. Actually, Toronto and Dr. Khashabji and Dr. Saipel really have pioneered the technology. It's known as ex vivo lung perfusion. So that's where you can take donor lungs and put them on a system where you can basically pump what's the equivalent of blood through them and put them on, breathe for them, and you can actually measure and assess. But not only that, provide interventions to those lungs as well. And there's a lot of work going into how we can change the lungs between the time of donation and transplantation to really optimize those for the recipient. And there actually are people looking at gene editing technology or other things, changing the blood type of an organ, for example, removing things like CMV from the lung. So there are lots of new exciting technologies. Again, we're in the discovery and developmental phase, probably not ready for clinical trials yet. But again, I think a realistic horizon probably is in the next decade or two, we're going to see some of these technologies come to the market.
And someone said that they were looking at your slides. It said that the double lung transplant individuals had average of 10.9 years after getting lung transplant because other complications happen and they can die from kidney failure, liver failure. But has there been anyone documented that lived longer than that? I mean, the average is 10.5 years, but are there individuals that have lived longer than that?
Yeah, great question. So yes, I have patients in my practice who are 25 plus years after their operation, who are doing very, very well. So again, it's just a statistic, and we don't know why people do so well. Sometimes when we don't know why people don't do well, the median survival is probably around 7.5 to 8 years. That 10 years you saw was what we call conditional survival. So if you survive the first year after transplant, that survival kind of creeps up closer to 10. Now, remember, these are the slide I showed are pooled statistics from, I think, about 15,000 recipients. And so it's it's everybody you can imagine from age 18 up to age, 70, whatever. So again, it's sort of a crude assessment of everyone who's ever received a lung transplant that's in the database. And so there's obviously different, your diagnosis at time of transplant, how old you are when you received a transplant. There's a lot of other factors that need to be considered. But yes, to answer your question directly, there are people who live for a very long time after receiving a lung transplant and do very, very well.
Okay. Well, thank you. The only thing I wanted to add was that Mark didn't share the fact that as a board member, he actually travels across the country for us and, coming to our walks in the community and sharing his story. And it's been really interesting to see how he could do that, because we had asked him to ask his doctors, like, is he okay to fly? And we didn't know that there was this actual test that you can do to say if the patient can fly. So how do people find out about that?
Did you want to take that one on, Mark, or share what you had to do?
I didn't have any testing. My doctor just said, we didn't give you new lungs to sit in the bubble. So go for it.
Yeah, wonderful. I think probably more applicable to people who are before transplant. So, air travel really is the major concern. Infection, of course, is one, but it's really the amount of oxygen that you need. So I think you need to really talk about flight with your respirologist. One of the big reasons, the big problem is that when you go up in a plane, the amount of oxygen in the air is the same, but the pressure in the cabin drops, while your ears pop. And as you go up, obviously, the higher you get in altitude, the lower the pressure of the air. And so there's really less oxygen that's available for your lungs to use. And so people who have a lung condition are at risk of getting low oxygen in the body as a product of that. The other complicating factor is that airlines will only let you bring on certain oxygen technology on the plane. So you can't take liquid oxygen or oxygen canisters, for example, on an airplane. You can only bring a concentrator, which really at best can probably give you like 3 liters, if you're lucky, of continuous flow. And so if people need more than 3 liters, we get a little bit anxious about flight because we don't want you to become hypoxic and really run into trouble on the airplane. So again, talk to your respirologist. What I will often do is arrange for a walk test to really understand what your oxygen needs are. There's another test called a high altitude stimulation test where you can actually simulate the atmosphere or the environment that's in an airplane. That's a very complicated and involved test and not one that we often use. We will in very rare situations where we really need to know. But often doing a walk test and really talking to your respirologist about your oxygen needs is probably the best thing to do.
Yeah. And I flew at 8 months and had no issues.
Fantastic.
I was doing really well by that point.
Exactly. Yeah. And same thing post-transplant, just, a quick chat with your team about your suitability to fly, but sounds like it's not a problem at all for you, Mark.
My wife makes sure I ask all the questions. I'm a believer in doing and ask for forgiveness, but she won't let me.
That works for some things, maybe not so good for others.
Yeah. So I'm just going to ask the audience if there are any other questions that people wanted to ask, because I think we had several good questions. And before we sign off, I don't know if there's anything that Dr. Scallan, would you like to share, or you, Mark, with the audience?
I would say ask any question you can think of. There's no question that's a stupid question. If you don't know it, ask. More information is better.
Okay. All right.
Yeah, I think I would echo that too. There's no question that I think is what we would ever consider silly or not worth asking. So absolutely. And I think I would just say that I would start a notebook. If you're someone who's starting to go through a transplant journey, really get a notebook and start to make notes about things that you've heard or that, there you go. Mark's one of our best patients for sure. But it's just write things down that you want to ask, or if you've noticed something. That's a great place to start. We can go down and cross off the list of all the things you want to know. But that's a great tool to have when you're going through this journey.
Great. Well, I want to thank you both for joining us today.